Thanks everybody for coming out today. Here to talk about U.S. India partnerships in healthcare innovation. This kind of goes back to the U.S. India Strategic and Commercial Dialogue. A lot of you know that's the highest level annual dialogue between our two governments. The U.S. Secretary of State and Secretary of Commerce once a year meet with their Indian counterparts. And a little over a year ago, it was September of 2015, when the Indian delegation was here in Washington, D.C., that the two governments had asked that we at CSIS lead a new U.S. India Innovation Forum. Innovation Forum, part of that is highlighting great examples of how U.S. India innovations in different sectors have really helped to meet certain social needs, but also to look at the way that the United States could be a stronger partner as India looks to stand up those institutions that really do help and strengthen the innovation ecosystem. Prime Minister Modi, as a lot of you know, has kicked off important new programs, the Atal Innovation Mission, the Stand Up Startup Initiative, which are really highlighting the great role that innovation and entrepreneurship can play in an economy. The United States is well acknowledged as having some of the best institutions in these areas. We've never really had an attempt, though, to try to corral these kind of capabilities and share them in a coherent manner with a foreign country. Every country, of course, wants to have the next Silicon Valley. And some corners of India, you'd say probably Bangalore, Gurgaon, Mumbai have elements of that. But a lot of corners don't. And we just came from a private conversation among a few of the key players and such a strong focus on how we engage Indian states directly, both in terms of being hotbeds of innovation, but also state being a good sized unit for carrying out and taking innovations to a bigger level. So we'll be looking at a number of sectors over the coming year, not just healthcare. We'll be looking at innovation in transportation, innovation in agriculture, but the government's really highlighted innovation in healthcare as one of the first sectors that they wanted us to focus on, just because the needs are so great. And as you'll hear from the folks that I'm accompanied with on stage, there are examples about how people have kind of broken the model to deliver better healthcare for a price point that we wouldn't have seen as possible not too long ago. So before we go into the substance, I also need to mention, as we always do at CSIS, that I am your safety officer for this event. So should something happen, a fire or some other crazy event, come on, nothing related to last night's crazy events, do follow me to exit the building. Also mention that I think I know why participation today is so high, because if we do have Obamacare get repealed, everybody's going to be looking for low-cost healthcare solutions. So timely in a whole other reason that most of us probably didn't expect a few days before. Also I wanted to offer my thanks to programs like this at CSIS. Can't be done without support from corporations, individuals, and foundations. And the Innovation Forum is underwritten by some terrific companies and partners, including Pfizer, including Qualcomm, including Uber, including the Wadhwani Foundation. So thanks to them also for making this kind of work possible. So let me first kick off. I'll introduce the speakers here and then ask them to kind of touch on what kind of need did they see, what kind of role have they chosen to play in terms of the U.S. India healthcare innovation space. So let me first start off with the gentleman who has become really my guru in trying to understand the India healthcare space. It's not something I'd ever spent a lot of time in. Dr. Krishna Udayakumar from Duke University. He's the head of global innovation at Duke Medicine and the executive director of the Innovations in Healthcare program, helping innovators to scale and replicate successful healthcare delivery solutions. Then immediately to my right is Sunil Wadhwani. Sunil is the founding donor of the Wadhwani Initiative for Sustainable Healthcare, the WISH Foundation. He's also known, and this is where we first met, as he was co-founder and chairman of iGate Technologies, which was one of the most visible and important technology service companies in the U.S. India space. Just to my left is Ms. Catherine Robinson, who's Director of International Government Affairs at Pfizer, partnering with IIT Delhi. She'll talk a little bit about that program, but of course Pfizer otherwise needs no introduction. And the brains of the shop on the other side, IBM Watson. Thanks to Rosalind Doctor for coming over for the program today, Director of Watson Health Policy at IBM, and just a huge repository of dynamic information on healthcare. So it's great to have such a group here today. Let me lead off by handing the podium, the lectern, and the microphone over to Krishna to get things going. Please.
Great, thank you. Good morning, and thank you, Rick, for that kind introduction. I think I'm now responsible for any mistakes that happen as the official guru, so we'll go with that. It's great to be talking about India, the U.S., and healthcare innovation as opposed to some other topics that folks are talking about this morning. So I think I'm looking forward to this conversation. what I want to do first is give you a bit of context, not an exhaustive understanding of the health sector or healthcare in India, but really what some of the key themes are and what some of the key drivers are for the need and the emergence of innovation. And really, it's a story about contrast and it's a story about disparities. So if you think about what we look for in the health sector, it's affordability in terms of access. It's also about quality. So if we think about cost, quality, and access, you can find in India, oftentimes next to each other, some of the best in the world and some of the worst in the world. That you've got high quality, amazing technology that if you can pay to access is incredible in terms of its experience. And people come from other parts of the world to get access to health services in India. And perhaps across the street, there are people who can't afford access to any care services. And we see these disparities play out over and over. And in that context, just to ground ourselves in some of the important data that drives this, first, we take a look at the health expenditure. It's incredibly low overall, as well as the government spending on health relative to other countries. The second is looking at the insurance market, so financing of care. We know that almost 70% of all health services are paid out of pocket in a cash-paying economy. And if you look at the graph on the right, that's a comparison to several other countries around the world in terms of the percentage of populations covered by any insurance scheme. And you'll see the one outlier, which is in the middle there, is India, relative to almost any other countries they would want to be or aspire to be compared against. And we know that statistics, including infant and maternal mortality, while they're improving, aren't at goals set globally, and we know that the workforce also doesn't exist. And if we take a look at that, the chart on the top left gives you some indication of the amount of spending, and you'll see India compared even against neighbors like Bangladesh fare poorly in overall spending as well as government spending on the health sector. And if you look at that intersection or the divide between the public and the private sectors, you can see on the bottom left that the majority of care is actually provided in the private sector, as you'd expect. But we also see that the cost of that care, if you look at the chart on the right, is significantly higher in the private sector versus the public. So that means even for people at the bottom of the pyramid, people in low socioeconomic status, they are making value-based decisions to actually purchase higher cost services from the private sector oftentimes than lower cost services from the public sector. So even when there's access, the quality, at least perceived quality, is lacking. And going back to how this all comes together, Vikram Patel and colleagues wrote a very nice piece in the last year and a half or so, really looking at trying to define what some of the key structural challenges were in the health sector in India. And they came up with 7 factors. The first is a lack of a strong primary healthcare sector. So knowing that primary care is really the driver of how people interact with the health sector and how health services and technologies are coordinated more broadly. The second, something we already saw in the prior data, there's both a lack but also an unequally distribution of the skilled health workforce across the country. Third, there's what they, in their article, would call a large unregulated private sector. I think we can think about this more broadly as the private sector being the driver of health services from both the service and the technology side, with very little coordination and certainly very little integration into the public sector. We already saw the low public spending on health, and we've seen obviously some of the outputs of that being health outcomes that are the worst that we would hope for. And built within all of these is the idea of fragmentation. So fragmentation of systems, but also the lack of the information technology systems to be able to share information, to share data as one of the connection points. What they call irrational use and spiraling cost of drugs and technology, I would call more broadly that certainly the costs of technology broadly defined and access to technologies are driven by who's able to afford them much more so than who has the needs for that technology. And of course, the driver of many of these other pieces is a weak governance and accountability framework and an understanding of the role of the central versus the state governments. So I would choose to look at this not as weaknesses, as perhaps others have seen, but really as opportunities. And this is where the innovation angle comes in for our work and for many of those in this room, which is if you look at the structural challenges and if you look at the trends that are happening in terms of rapid aging, the growth of non-communicable diseases, the infrastructure needs, these are all opportunities that are being met by entrepreneurs, social entrepreneurs, and the like. And what does that look like in India? One of the best known enterprises in the health sector is called Narayana Health. They're based in Bangalore, and they now operate about 5,000 beds offering tertiary care, secondary care, health services. They started out offering cardiovascular care, heart services, and saw the need for people to get care in an affordable way that didn't exist 15 years ago. And what they are now able to offer at one of the highest volume facilities in the world are U.S. quality outcomes. And if you take an open heart surgery, a coronary bypass, as one example of a very high-end procedure that involves services and technologies together, they've now proven that they can offer outcomes that are similar to what we get here in the U.S. In the U.S., we would expect to pay anywhere from $50,000 to $200,000 for a procedure of that kind. They're now doing this routinely for under $2,000 in India, and now have expanded their work to actually be relevant to the U.S. and try to disrupt the U.S. market by creating a hospital in the Cayman Islands, which we can come back to. And on the other end of the spectrum, from this gleaming hospital, you see what's happening in terms of social enterprises in urban slums and in rural areas. And one of the organizations I'll highlight here is called Operation Asha. And they started out trying to address this huge unmet need in treating tuberculosis patients. Now imagine you live in a slum, you're the breadwinner for your family, and you've been diagnosed with tuberculosis. The old model was you now had to have directly observed therapy, which meant you lost your job, you lost your livelihood, you spent almost every day going to a government center that was not anywhere convenient to where you live, to be able to watch them for them to watch you take your medicine, because that's how we avoid complications and drug resistance. What Operation Asha has done as a private sector nonprofit is to flip that model on its head to say, we can bring technology and service delivery to the client. So they have set up shop in slums, in rural areas. They have included an affordable technology platform that does e-compliance, where they're able to actually do better matching using biometrics, and use that to actually create a model where people don't lose their livelihoods. And the data they have is that more people complete courses for tuberculosis in their model than any other government model, and it's actually cheaper than any government system. So these are the types of innovations we think are incredible to look at, and the types of principles they're putting into practice aren't rocket science. They're ones that we think about, but we have a lot of difficulty in actually putting into practice consistently. So it's about the patients as consumers. So how do we serve our consumers and clients? It's about using proven technologies like mobile phones in very disruptive ways. It's about right-skilling the workforce, making sure everybody's working at the top of their skills and their competencies. It's about standardizing to reduce variability and improve the consistency of the care experience and the outcomes. And it's about creating asset-light models, which we don't do very well at all, certainly in the U.S. context. When we think about healthcare, it's about highly paid health professionals, it's about incredibly capital-intensive buildings, and it's about very high-end technology, where we should really be thinking about the outcomes and working backwards to find the lowest cost and most asset-light mechanism to get there. So we started studying this about 8 years ago and tried to answer the question, are these unicorns? Are these models that are one-offs that can't be replicated? And the more we looked in lots of different parts of the world, we realized that there were incredible innovations that were already happening, especially in places like India. And that's not surprising. This is the divergence, the contrast that I want to come back to, which is that in places around the world that have the most resource constraints are oftentimes the places where the most creative and transformative solutions are being developed. And that's why we see in India, existing side by side, enormous systemic challenges in the health sector, and at the same time, some of the best innovations anywhere being developed in the world. And to pursue this work further, 5.5 years ago, we created a nonprofit called Innovations in Healthcare that's hosted at Duke, We co-founded this with McKinsey & Company and the World Economic Forum to jointly drive toward a vision of scaling the best healthcare innovations from around the world. We approach this through 4 programmatic lenses. The first is you've got to figure this out. And I would hypothesize, and I think our data shows, that much of what we need in the world aren't brand new solutions for unsolved challenges. Somebody somewhere has figured out a solution or something that's very close to a solution. What we really need is the ability to scout for innovation, to be able to curate the very best in the world. Secondly, we have to find ways to then help those innovations to strengthen their own abilities to scale and grow their impact. Third, we've got to actually understand and bring evidence to bear to know what works and what doesn't work in scaling the impact of innovation. And finally, if we can put all of those together, we can work together with partners to achieve scale of impact in places like India, but also in places like the U.S., where we have significant health needs. As I mentioned, we do a lot of our work in India, but take a global lens. And over 5 years, we have assembled a network of 67 organizations that are operating in 49 countries, serving more than 30 million beneficiaries. And of those, India, as you can see from the map, is the largest dot, the biggest cluster of innovators that we have. More than 25 companies that we work with, for-profit, nonprofit, all driving impact. And these range from provision of direct care services to technology companies that are improving the experience or the costs of care. We see healthcare financing mechanisms like microinsurance schemes. We see health workforce development models, and we see infrastructure and support services, all as different ways to impact the health sector. And what we think is needed to strengthen these organizations is access to expertise, mentorship, capacity building in everything from organizational skills around business support, around accessing the best networks around the world. So we've got incredible entrepreneurs that are acting in isolation of being part of a larger ecosystem, and if we can solve that network challenge, we think we can scale impact more effectively, and of course, access to financing. And if we look just at a subset of 25 of the 67 organizations we've worked with, where we track even stronger data, since we started working with them in the last 4 years, they have been able to raise more than $56 million. None of it directly from us, but with our support to build their organizational skills and the capacity to access funding more broadly. And one of the large programs we run that does this work is called the Social Entrepreneurship Accelerator at Duke, or SEED, which is a partnership between our nonprofit, Duke University through its Global Health Institute, and the business schools through the Center for the Advancement of Social Entrepreneurship, where we are bringing to the table the practitioner perspective, what's actually happening in the field in India and East Africa. We're bringing the social enterprise perspective from CASE and our business school that spent more than a decade actually understanding and studying what works and what doesn't work in scaling social impact, and putting this through the lens of global health. And we are especially interested in India, given the cluster of innovation that we see, not just to solve problems in India, but to solve problems in the rest of the world. So one of the things that we did several years ago was take more than a dozen health system leaders from the U.S. and the U.K., including the National Health Service in the U.K., and take them to India for a week and actually let them see, touch, feel what innovation looks like in that context. So they weren't reading about it and seeing pictures. And they came away with a profound understanding that was very different than what they would have thought otherwise. And you see the note on the bottom right. All the leaders from the UK then got together and actually wrote a report that's public, talking about what the UK could learn from healthcare innovation that's happening in India from seeing it in person. So we went to Narayana Health, as I mentioned, LV Prasad Eye Institute, Vatsalya, LifeSpring. We've partnered with the Commonwealth Fund here in the US to write case studies through the lens of frugal innovation, which is also especially fruitful in India to look at. And here we looked at Narayana Health, as well as an organization called Basic Needs that is operating in India, but in 11 other countries around the world, bringing together community development, vocational training, and access to mental health services to solve enduring challenges in mental health that every country faces. We also have then moved beyond writing case studies to actually working with organizations, and we spent the last year and a half working with Basic Needs to help them take their model from India, from Kenya, and bring it to the US to show that this is a model for reverse innovation that can work. And they have just received 15 months of funding to demonstrate this model in practice in Detroit. So we're really proud to be following that work and supporting it to show that models that have been developed and scaled and proven to have impact in India then come back and show value in the US. And we've also looked beyond the delivery space. We know that the improving delivery is incredibly important, but you also have to have financing and policy levers that support the delivery space. And so we've been working with Mark McClellan when he was at Brookings Institution, and we were proud to welcome him to Duke in the last year to lead the Duke Margolis Center for Health Policy. And we've taken the lens that Mark has developed around the concept of accountable care. Not about accountable care organizations as they're applied in the US, but the principles of accountable care. How do you define a population, and how do you define the right health and economic metrics to improve the population? How do you put in place the policy levers to drive continuous quality improvement? How do we align financial and non-financial incentives? And how do we put the policy and financing mechanisms in place to allow for care coordination and transformation? Those, we think, are enduring principles that apply around the world. So we've written case studies in India, in other low, middle, and high-income countries of accountable care being put into practice and develop new frameworks that can then be applied more broadly. And we've also done this work through the lens of diabetes to show that what's working in India in diabetes can also work in other parts of the world. So I will end with this crazy graphic that is still a work in progress, but is one way that we've started to think about putting all of the pieces together. So if we're going to solve a complex problem, and almost any problem in the health sector in any part of the world is a complex problem, the first thing we've got to do is start by problem sourcing. So really understanding from the perspective of multiple stakeholders their challenges and what the constraints are. And moving from that to a function of innovation, scouting, and curation and integration. As good as the innovations are that I described to you, each of them, I would say, are point innovations. They address a piece of what we need in the health sector. And what we really need to find are the best point innovations that, when combined and integrated, can have impact at scale systematically. So we need to be able to integrate, we need to be able to model the impact, and then move this, working with key stakeholders, to a demonstration program where we can actually bring different innovations from wherever they originate in the world, model their adaptation into a local context to solve complex challenges, and then show that it can work and do it in a scaled way. So to put all of this together, I would say that if we look at the health sector in India, there are profound disparities, profound contrasts. Not only are there significant gaps across the system, but it's also this beacon for innovation, not just for local needs, but for global needs. Second, where we see the opportunity is for capacity building to establish relationships and really move forward with the lens of bidirectional learning. And third, I would argue we have to move beyond single innovations for single small challenges to actually now move to integrating different solutions together to solve systematic challenges. So I'll leave it there and look forward to a great discussion. Thank you.
Well, that articulates what the role of the Innovation Forum is better than I could ever do, specifically as we look at healthcare. And now we'll talk about others that actually have practicing functions, starting with Sunil, who really put his money where his mouth is when he saw the need there. So Sunil, let me hand it over to you.
Sure, thanks. Thanks, good morning. I don't have a PowerPoint, but fortunately for you, I'm easy on the eyes. If you're looking at me. I'm what you might call an entrepreneur. I've started a few different companies in the US in the healthcare field and in technology services. The largest of these companies grew to over $1 billion in revenue. I've taken a couple of these public, so I've learned a little bit about what kind of works and what doesn't work when you're trying to scale innovation-based organizations. I've also angel funded maybe 45 or 50 companies in the US and in India, again, in different areas of innovation, and learned some more lessons of what works and what doesn't work. On the social side, I've been funding some healthcare NGOs in India for over 10 years. And through them, I've traveled to remote parts of India. And I've seen firsthand, and many of you have, I'm sure, just how broken the healthcare system is in India, and it's the same way in other developing countries. If you're poor, whether you live in rural areas or in urban slums, and especially when you're in low-income parts of the country, the healthcare system basically doesn't exist. And I'll give you a little example. As I was traveling, this was 3 or 4 years ago, I met a lady, this is in the state of Rajasthan, which is a large low-income state in northern India. Parvati Devi was her name. Farming family, she and her wife were both farmers, below the poverty line. And she started feeling, I mean, when I met her, she was describing what had happened to her a year ago. And she had started feeling intense pain in her back, a weakness, pain running down her legs, et cetera, et cetera. So she spoke to her frontline healthcare worker. In India, they're called ASHA workers, described the problem. The ASHA worker gave her some pills. She took the pills, made no difference. ASHA worker says, go to your local primary health center. She's not well, so her husband has to take time off. So he loses his day's wages, she loses her wages. They go to the primary health center, there's no doctor on site, so they go back, they've lost the day's wages. Go back a second time, no one on site, go back. Third time they see the doctor, equipment out there isn't working for the test, so he says you have to go to the district hospital, which is now, much further away. She comes back, net, she's unable to work. Turns out she has deep diabetes, stops working, so that family that was already tragically poor now has lost half of its income, right? A few months later, I'm in Delhi, and I meet these 3 young innovators from IIT Delhi, and they've developed this really neat, ultra-low-cost device for measuring blood glucose. But they haven't been able to raise financing to commercialize this. They haven't been able to get governments interested in buying this thing. So here they are with an idea that could solve the problem that Parvati Devi had of diagnosing this diabetes early on, but these dots weren't connecting. That's the challenge healthcare innovators have, especially when you look at innovators who are targeting the bottom of the pyramid, whether it's rural areas or urban slums. All the commercial models, by and large, don't work because the price points are very low when you're selling to people at that poverty level. Costs of distribution are extremely high, and in fact, in many of these cases, there is no distribution other than government distribution systems out in these very remote areas. So you've got high sales and distribution costs, you've got very low price points people are willing to pay. So these are not the kind of business models that venture capitalists will invest in or angel investors will invest in. That's the challenge these innovators face. So how do we deal with this? What are some practical things that we can do to start connecting these dots to improve things in countries like India? And ultimately, a lot of this innovation can come back and be helping us right here in the US. Number one, I think we have to start looking at defining innovation in a much broader sense than just technology innovation or device innovation. The biggest innovations that make differences are innovations that will improve delivery systems, because those are the systems that are truly broken in countries like India. So innovations, process innovations, system innovations that can help with getting physicians into remote areas, better training of frontline workers, mHealth, eHealth, things like that, better governance and accountability systems, those kinds of innovations, in fact, go a much longer way in improving healthcare than a lower cost device for diagnosing X or treating Y, et cetera. I mean, those are needed. But in fact, the examples that Krishna just put out, of innovators in India, interestingly, are all health delivery systems. So Narayana Health and LV Prasad and all of these are more innovative delivery systems rather than, a specific device or something. So that's number one. We have to think of innovation broadly. Secondly, it helps to have some overall focus when we're looking to, change the, bend the curve, change the game, et cetera. And what Krishna said, I think, is right on the money, that primary care should be that area of focus. When you look at any developing country, any low and middle income country, primary care, as Krishna said, is where the population, and especially the poor population, interacts with the healthcare system. And when you look at, again, countries like India, that's the aspect of the healthcare system that's really broken, needs to be fixed. So if we can look at innovations with a focus on does it help primary care, I think that's very helpful. So that's number two. Number three, I would suggest that if we look at India as an example, why don't we, in a systematic way, go about identifying the 300 to 500 most promising healthcare innovators who can make a difference? There are ways of doing that, and I'll come back to that in a couple of minutes. And the reason I say identify them is because a country like India, I'm guessing, has over 10,000 healthcare innovators. Other developing countries also have thousands of healthcare innovators. So the challenge isn't innovation per se, it's identifying the most promising innovators and helping them to scale up. That's the challenge. So that's point number 3. Let's identify the most promising and help them scale up. Number 4, scaling up takes money. It takes a lot of things, but money is very important. So number 4, I would say in a country like India, can we, over the next 3 or 4 years, develop a $100 million to $200 million healthcare innovation fund, focused strictly on healthcare, and focused really on social innovators. These are not people that your typical venture funds, et cetera, are funding, but that's the kind of money that we need. So can we raise 100 or 200 million for that? And I believe we can. So let's kind of work on that. 5th, I would say these innovators are working in isolation by and large. They're very small by and large. They're working in 10 villages here or 5 villages there, et cetera. And in any area of innovation that you might look at, there's typically 50 or 100 or 200 innovators. So if I look at how to improve child immunization levels, guaranteed, there'll be over 500 people in India, innovators doing things differently, but they're not connecting with each other, they're not collaborating. So my 5th point would be, can we develop a knowledge hub, basically an online portal, through which innovators can interact with each other, they can connect, collaborate, but not just with each other, but also with investors, philanthropists, foundations who might help fund them, mentors who can help them grow, et cetera. Very doable, and I think the value add from that would be extremely high. And then finally, in a country like India, with the assistance of the US, can we put all this together and build a large-scale, ongoing national ecosystem for healthcare innovation? This doesn't exist right now. Like I said, these innovations, everything is very fragmented. Can we try and pull this together? So seeing all of this, as I was traveling around the country, I said, as Rick mentioned, let me put my money where my mouth is. And about 2 years ago, I set up a healthcare foundation in India called the Wish Foundation. And we started working on many of these things. We said, let's focus on primary healthcare. Secondly, we said if we want to do things at scale, we have to partner with government. So that was part of our strategy. We said identifying the most promising healthcare innovators is crucial. So we teamed up with the World Bank about 15, 18 months ago, did the first ever nationwide search, systematic nationwide search in India for healthcare innovators. We contacted over 2,000 of them. And from the 2,000, we've selected about 200 that we think are the most promising. And my foundation now has started working with the first set of about 20 of these innovators, giving them small grants, giving them management technical assistance, helping them scale up. On the state government side, in terms of actually implementing all of this on the ground, we said, why don't we develop a model where we can implement, these model for implementing these innovations to improve primary healthcare. We developed a model for doing this in rural areas. About 18 months ago, we approached the state of Rajasthan, which is a large low-income state, again, in northern India, 70 million people. Approached the state government and said, why don't you turn your worst performing healthcare clinics in the most remote parts of your state, turn them over to us, we'll run them for you. Here are the interventions we will make. Here are the 35, 40 quality metrics that we'll track. We told them that in the initial 6 to 8 month pilot period, we'll cover all the costs of these clinics, even though these are government clinics. But once we show that our system is working, we want you, the government, to take over 80 or 90% of the cost. And we will scale back, and we will find other funding partners to help us fund this. Rajasthan government amazingly agreed to this. I was really taken aback because we were a brand new foundation, no track record. I thought they'd give us 10 clinics or 15 clinics to run. They gave us almost 200 in the worst parts of Rajasthan. Rajasthan is a state in the desert, tribal areas. It's a tough places, very high absenteeism, impossible getting physicians out there. Suddenly we had 200 clinics. In 90 days, my staff was running ragged. In 90 days, we took these 200 clinics over, got them cleaned because they were dirty places you wouldn't want to get in within a mile of, got them cleaned, got them painted, hired 550 staff, including physicians and nurses, et cetera, got medical equipment in place, got medicines, set up a supply chain system, and then we introduced a whole bunch of these innovations. mobile health systems, systems for training healthcare workers, low-cost devices for XYZ, et cetera. So we've been running these for a year, and the results at this stage, touch wood, are absolutely remarkable. Our outpatient volume, and these are in very remote areas, when we took these 200 clinics over, we were treating about 20,000 patients a month. Last month, we treated over 100,000 patients. Why? Because now people in these remote areas know you'll get treated, there'll be a doctor on site, there'll be nurses, the equipment will work, there'll be medicines, etc. So that's a working example of a rural health program that we've set up. And again, these 20 innovators we're working with, we brought all those innovations. I mean, this is a giant test bed for these folks. And now the Rajasthan government has started ordering many of these devices and innovations in large volume. About 6 months ago, 8 months ago, the Delhi government approached us. They were setting up this very large-scale Mohalla clinic program in the urban slums of Delhi. They selected us as their partner. So now we are running the first 100 clinics of the Delhi government in the Delhi slums. Their volumes are even higher, so we're treating about 200,000 people a month. Again, we brought in a whole lot of these innovations over there. Now that these are working, now we've got several other states approaching us that we're speaking with, and we'll be starting operations pretty soon in these different states. So that's kind of where we are. So the point is, a lot can be done if we think about innovations broadly, if we think about making change in a focused kind of way, and again, I suggest that primary care is the way to do it. There is a lot of innovation out there. The key is how do we help them scale up? Government partnership with government, I think, is key. And I'll leave you with this final thought, which is that in countries like India, but India is a great example, there has never been leadership in government, both at the central and the state government levels, as good as there is now in terms of chief ministers or governors who actually want to make change, positive change for the common man. We haven't had this for a long time. We have it now. We need to make the most of this. So thank you so much.
Great.
Well, now on to a large company that's doing its part to help smaller startups in India. So Catherine, if you want to talk about Pfizer's engagement.
Excellent.
Thanks.
I'm not sure who's controlling the slide decks, but,
Press the down arrow.
oh,
Keep it.
perfect. Thank you. Good morning, everyone. Thanks for being here. I'm Catherine Robinson with Pfizer's International Government Affairs Office, and I'm here to talk to you today a little bit about one of our social responsibility programs that we're partnering with the Indian government on in terms of trying to capitalize on the talent and entrepreneurs that exist in India to help provide solutions to healthcare challenges. I think from the previous speakers, we learned a lot about the challenges that exist within infrastructure and bringing healthcare to the people of India. I will focus a little bit differently on how new ideas are developed, come to fruition, and then are commercialized. So first, let me just tell you a little bit about Pfizer. As everyone probably knows, we're one of the world's largest biopharmaceutical companies. We have a long history in India, more than 65 years. We do manufacturing, R&D, testing, everything, part of our business operations are done locally in India. And we're particularly excited about one of our newest facilities, which will be the largest sterile injectables facility in the world, which is opening in, has opened this year in India. In India, we have about 8,000 employees, and we do R&D, as I said, in many different clinical areas. And 65% of all of our manufacturing is done in India, and then we do a significant amount of that manufacturing is then exported to other countries around the world from India. So we, with all of that, we are the 8th largest pharmaceutical company operating in India, which is quite an achievement given the number of companies, of pharmaceutical companies in India as a whole. interesting. I didn't put those design features in the slides. So.
Innovation.
Innovation, exactly. Can't use the most basic technology platform that exists, PowerPoint. But so specifically this year, Pfizer launched a new program in collaboration with IIT Delhi. And it is to work with the Indian government on its initiatives for Innovate in India, Startup India, and to really develop local entrepreneurs. And the partnership provides funding, resources, expertise, and infrastructure that allows innovators to bring their healthcare ideas and innovations to patients around the country. And it's been officially endorsed as a Startup India program by DIPP and is basically an incubator accelerator program that has two specific components to it. First is for innovators that have sought to translate their healthcare ideas into a new business. So they have an idea, but they haven't quite figured out how to create that idea or bring it to the patients. So in partnership with IIT Delhi, they're given a space, they're given access to resources, to other innovators to really kind of further develop that and see if they can come up with a there that's there to help patients. And the second are for another set of entrepreneurs, those that already have a proof of concept, those that have developed an idea and now need to commercialize it. And in that area, we're providing support, again, through IIT Delhi and helping those innovators patent their ideas or seek the legal protections that they need so that they'll be able to commercialize it and scale up so that the patients will be impacted. We're providing the funding of around 500,000 rupees to each of our applicants. We provide annually up to 4 in terms of innovators who are looking to develop a new idea or to test a concept to see if it's reliable. And then 10 applicants will be awarded help with in terms of patenting and commercializing a new product. So as I said, the program just started this year, and so far we have awarded 5 grants. 2 have gone to innovators that are looking to further develop their concept, and 3 have gone to innovators that have a proof of concept but are looking to commercialize that. And so they're all very interesting, different programs that you'll see. So the first that was for incubation within the IIT Delhi system is an early diagnosis system for typhoid. It's a portable device for early stage diagnosis that will help with accurate diagnosis and further with typhoid fever. So that, again, is one of the first awardees this year. The second is a novel wearable device for protection from respiratory hazards from air pollution, which is also an area of need in India. And so these 2 innovators are working to further develop their projects. In terms of the other 3 that are working for IP filing support, it's 3 very different technologies that have been developed, and we will be working with them in conjunction with IIT Delhi to help them move through the patenting process in India so that they're able to file and protect their patents, which is critical for the commercialization of the technology further away. And that's, I think, one of the real challenges for innovation is oftentimes you have a great idea and you can prove that it will work, but then how do you scale up? How do you commercialize it? And one thing that I think is important as we look at creating the innovation ecosystem in India is how do we create a culture that rewards innovators and protects their ideas so that they can be commercialized. When your commercialization is a huge challenge and it takes significant funding for it to happen in this space. And one of the keys to commercialization is being able to protect your IP. And so one of the aspects of this program is really trying to build that culture within India and also helping entrepreneurs move through the process, which can be quite daunting. Specifically, It's not an entrepreneur that is working through this specific program with us, but it's another entrepreneur that we're working with in one of our other CSR programs in India. And they've developed this great technology, basically a handheld device that can be used for early detection of breast cancer. And they can do it for under, I think, $5 in terms of detection. It's really a remarkable device. But one of the challenges they found was they knew they had to protect their IP because it was really a game changer in terms of detection. But they had significant challenges moving through the IP system in India. And they were actually able to finally do it, and that actually has led them to getting several investors and VCs interested in their product. And so now they're able to scale up, and they're working in several different states. But again, it's really creating that environment that allows this to happen for those entrepreneurs. These are just pictures of the awardees from this year with the Indian government when the program was announced earlier this year. These are the 3 for the IP. And then lastly, with the Prime Minister and with his endorsement and support of the program from January. We've also just kicked off the second round of applications for Indian innovators for the second awards that will be granted before the end of the year. So anyone wants any further information, happy to provide that to you, and look forward to questions and answers. Thank you.
Great, thanks. Well, one thing that we had a small session among some of the healthcare leaders upstairs just before this, so I could borrow their brain power for some of the work I'm supposed to do. And data came up so often and in so many different ways. And of course, IBM Watson is known as one of the great actors in this space. So Ross, I don't know if you want to sit or stand, but great to have you here. Thanks for coming out.
Thank you. It's a pleasure to be here. I'm very excited to talk about innovation and partnership in healthcare. Rick, you set this up very nicely talking about data. There is no industry more ripe for transformation than healthcare because of all the data that's out there. Every 2 years, the medical information, the science information, all the information that doctors come up with doubles. We, each one of us, is going to create 300 million books about our own personal health, our behavioral health, our wearables, the IoT when we stand on a scale, weather data, how we interact, social data, about ourselves in our lifetime. 300 million books. 80% of all this data is unstructured. It's not in neat little formats, and it's not in one place. Oh, my mic's not on?
Yeah.
You want to tell me how you want me to turn it on?
Yeah.
Man, you missed the good part, guys. Were you? I think you in the room were able to hear me.
Yeah.
Great. There's all this data. It's unstructured. It's not in neat little formats. It's not all in one place. And previously, we couldn't get access to this. Medical professionals came to IBM, and they said, we believe that we could cure cancer. We could slow diabetes. We could end heart disease. If only we could find the needle in the haystack. If we could connect disparate data sources and use it to predict and transform medicine. And now is the time we're able to do that, and that's because of advances in technologies. Because of the Internet of Things, where we have access to more data. Because of cloud computing, where we can store more data. Because of high performance computing, where we can analyze more data, large volumes of data sets. And because of cognitive computing. We are now at the point where we can transform healthcare to find actionable, evidence-based insights for improving the quality of care and access to care. So you hear the term cognitive computing. I think somebody called it AI earlier. At IBM, we call it Watson. Did anybody see IBM Watson play Jeopardy 5 years ago? All right, we got a few folks in the room, hopefully more of you watching. What IBM can do in Watson, our cognitive computing, is it can understand natural language. It understands how you and I speak. It can parse a sentence it also can understand how doctors speak. It understands what is behavioral health, what is a medical condition, what is just biological information about a patient. It then reasons, it then applies that data with other data sources and says, okay, here's a hypothesis. Maybe this is how we should look at this data and how it interacts together. It then learns. The more feedback you give it, the better its insights and ability to match your needs, similar to Netflix and finding the movie of your choice. And importantly, it interacts. It asks, if I knew more, can you tell me more about this? I'll be able to correlate and reason better. I'll be able to get more evidence to substantiate a hypothesis. It interacts with us. It currently is speaking English, and we're teeing up to learn 8 more languages, including Hindi, excuse me. We can't do this alone. All of this transformation, all of this data, not one person, not one country, not one entity owns it all, and we have to do it through collaboration. We have at IBM, you might not know this, when you check out your phone and you get the weather, thanks, that's IBM. We have also acquired a lot of technology companies that are leaders in niche areas of healthcare, including radiological imaging. We also have lots of partners, and I meant to check to see if Pfizer's on our list, but you're one of our partners and we appreciate it. We are partnering with drug companies, we're partnering with device manufacturers, we're partnering with patient groups, we're partnering with medical experts, because through those partnerships we can transform healthcare. I want to spend a minute on Memorial Sloan Kettering Cancer Center, which is one of the oldest cancer centers in New York. It was one of the first partners of IBM Watson Health. They're the ones that came to us when they saw Jeopardy, and they said, there's no greater natural language problem than cancer care today, because the information is in such disparate places, and it's not in a structured format. If we can apply the IBM Watson that won Jeopardy to cancer care, it can be a game changer. So we worked with MSK, where their oncologists trained Watson to provide the evidence-based insights that oncologists can use to better personalize cancer care for the patients that they see. But it's bigger than MSK. Cancer is a problem that afflicts people worldwide, and they wanted to make sure that the same access to quality care that one could get when one goes to MSK in New York could be accessible by people outside of New York, outside of the US. And that's our example of what we're doing in India. India has a great need for this. In the US, there's one oncologist for every 100 cancer patients. In India, it's one oncologist for every 2,000 cancer patients. And as I said, medical information doubles every 2 years. This is a strain on oncologists in India to keep up. And also, I didn't say this earlier, but Watson reads natural language, right? It can read 15 million pages in 1 second. This would be a tremendous resource for all of us in our daily lives, right? We'd be much smarter if we can have access to that. And cancer mortality is growing. So we partnered with Manipal Hospital, which is, many of you who are experts in India know much more about that than I do, which is 16 hospitals, and MSK, to give them access to IBM Watson. And it's to address the problems that they were facing that I just articulated. I can spend a lot more time talking about it, but what I thought would be really good is for you to hear the oncologists in India talking about the collaborations themselves.
The questions that cancer poses us are not easy to answer. They are about life, death, faith, love, and so much more. With IBM Watson, doctors access a breadth and depth of information. Information that can lead to insights. Insights that help physicians identify unique cases and personalize treatment options for them. Because no two cancer patients are the same. And yet, there are thousands of cancer cases that physicians can learn from. The collective knowledge of doctors from the world over can now be shared across the planet. Cancer has gone through an explosion in the Indian subcontinent. The disease claimed 680,000 lives in 2014 in India, with an acute shortage of oncologists in the country. The ratio of specialist doctors to cancer patients is about 1:1,600. As a result, 60% of cancer patients are unable to access quality cancer treatment, and almost 70 to 80% are diagnosed late, which reduces chances of their survival.
As a doctor, my duty would be to do justice to my patient and that I do the best for my patient in terms of diagnosis, in terms of management, in terms of alleviating the patient's suffering. And there's so much of knowledge available in the world today, not just in terms of books, but also from conferences, also from journals. Knowledge is just bursting everywhere. Even if I put something on the internet, I'll get loads of information about that particular disease. So it would be good if technology would be able to help me in choosing the right kind of treatment for my patient.
Cancer is a disease where the first treatment has to be the best. And it has to be based on evidence, avoiding over-testing. So how does one doctor gain insight? How can one doctor analyze millions of case files and identify treatment options? How can one doctor know about medical advances around the world? How can a doctor get assistance to make more informed treatment decisions?
The first treatment is the best treatment for them, and multidisciplinary approach and access to all the literature available is what makes that first difference to the patient. Currently, we use a multidisciplinary tumor board where 3 or 4 doctors sit and try to assimilate humanly impossible knowledge. I'm a robotic surgeon. I know the importance of technology at Manipal Hospital. Now imagine if we have an artificial intelligence like Watson we have at Manipal Hospital, which analyzes over 15,000 journals, millions of articles published, and all the evidence available at one shot of fingertip, which is highly reliable and 4 oncologists put together, which is most evidence-based. What more an oncologist needs? And if I'm a patient, this is the best and first and best chance available. So we at Manipal, we welcome this Watson. It is not going to help doctors alone. This will be a privilege for patient to take that, which moves towards the most evidence-based approach to the patient and fantastic first and best chance, which is most important in oncology.
The lives of the patients are in the hands of the doctors. There are 2 parts of any medical problem. There's the biology, which the doctors take care of. And then there is information. What Watson gives the doctors is access to research data, related case histories, and current procedures. Information that helps a doctor identify potential treatment options. IBM Watson at Manipal Hospitals.
So that's a flavor, and I want to expand on that because we mentioned some of the principles you mentioned, scalability, mobile technology. We are now offering, or Manipal is now offering the access to the information that MSK doctors have, that they have, even to patients in India that do not go to Manipal Hospital. You can now go, and I think I have a slide on this. You can go to the Manipal Hospital website, and you can click on, I'd like a second opinion based on Watson to be sent to my oncologist. And you can do this online, or you can do this through SMS. And this just went live in August. This is our goal, working with MSK, working with Manipal, and working with so many partners to democratize access to quality care regardless of where the patient sits. I'm going to end, and I'm always happy to talk more in depth about how we created Watson and what it does and where we're partnering with, I should make it the screen show, but that's okay. With our quote from our CEO. I was hoping to make another statement today about how great it is to be led by a female leader, but can't quite say that. Health is our moonshot. IBM is committed to bringing these new technologies, the cognitive computing, be able to get data-driven insights throughout, from and to the entire healthcare ecosystem in order to offer precision medicine and better health to all. But we can't do that without partnerships, and I welcome the partners that are here on the table, and we welcome more partners. Our APIs are open, and we're always looking for collaborators, and as our commercials say, what would you do with IBM Watson? Thank you.
Great. Well, before opening the audience, I thought I'd get things rolling here with a few questions for participants here. And let me just start, Ross, I wonder if you can talk, I mean, when you think about a country like India, is it, you talked about an Indian organization as a client, but big picture, I mean, do you look at India as primarily as a place for generating data, because there's so much that's obviously coming from a place like that, or is it a place where data to be applied? I mean, certainly it's a mix, but what do you think of first and foremost for a country of that size?
I think you said it perfectly, that it has to be a mix, that we have to, data is, you want the data, the value of data is the more data and the more we can to reason with that data and say, okay, this is what we've learned in India, how does that apply to what we've learned in Africa, what we've learned in the US, where are we seeing trends? Our discussion earlier says clinical trials. The US is always trying to scale clinical trials, drug companies, and there's a source of where data from India could be helpful, and that information can go back. And lastly, we like to partner. We partner with Pfizer, we partner with drug companies all over the world, and it's their data with our data that can really make the difference on drug discovery and bringing products to market.
Catherine, you know, we oftentimes sort of think about India and when regulatory issues, when great ideas come up, you sort of compare and contrast versus other markets. You know, as India looks to kind of increase and scale up its own work on healthcare and innovation, are there countries that, you know, you run across that you deal with that sort of feel like that's a good target, like next step up? I mean, sometimes maybe Israel is brought up in a few contexts or places like that. Is there another country or two that you run across that you think has figured out something that is maybe one level higher that you kind of run across?
I mean, that's an excellent question and a tough one too.
Yeah.
and on 2 hours of sleep and not a positive way, it's even harder to answer. India offers so many opportunities. I mean, just the population size and pulling the data together, you know, as we've been learning in terms of what's possible. And then also just the level of entrepreneurs and the companies that exist. It's really different in nature than we see in a lot of other markets around the world. So I think it's every market you have to really tailor for the specifics to meet that. But when you look at what governments are doing well and others, you know, I think one area where we're really hoping to make some improvements in India is in the space of clinical trials and trying to look at best practices around the world for clinical trials so that you really can work with patients in India to bring them the new cutting edge medicines and make sure that everything is tailored to the population set in the country. And so you do have to look at countries where they have seen substantial progress. I mean, Israel did make substantial progress or changes to their clinical trial system years ago, and you've seen a drastic change there. There are a couple of countries in Latin America where they really are leaders in clinical trials as well. So again, I think it's looking around the globe, seeing what's been done well and what you can adopt and what best practices exist and how you can tailor it for each individual country. Because you know, the scale and the size in India is dramatically different from a lot of other countries. So what works one place may not work in India, but you can take the idea and concept and kind of change it to fit the scene. So.
Yeah. Ross, you had something?
I was just going to add in terms of leadership on policy, we've been talking about data, and I'd be curious to know what others say, but you need to have appropriate data policies in place in that country, one allowing for cross-border data flow. We cannot offer these services. You can't get the expertise from MSK unless the data can flow across nations. And we want the data from India to flow back to help others be smart. And also access to data, and sometimes the government owns that data about its citizens. But if you want to do research and you want to do clinical trial, if you want to incorporate real world evidence to make better decisions, then we need data access policies that reflect the changing dynamics. Yeah. And I just, example of that is in Finland, where they have a progressive data policy, and they've invested in innovation in healthcare to pull together data, to train people with skills. IBM is providing its IBM Watson. We're hiring researchers and different Finnish inventors or investors and innovators are creating solutions to help the healthcare of that country.
Sunil, an area you touched on just briefly, but to me is always like the most fascinating. So you go to a state government and broach a big idea. How do you approach something like that? How do you convince a state government to hand over, essentially to a private entity, a function that has traditionally been, its own, especially as you mentioned, one that is relatively unproven. I mean, yours was a startup idea. You've got experience in the sector for sure, but how does that conversation transpire? Because hopefully for people in this room, as we talked about upstairs, you got the federal level, state level, and then institutions. And state level kind of gives you both scale and, if you find the right state, the flexibility. So how do you start that conversation with a state government in India?
It's a great question. It wasn't easy, as you can imagine. But here's what happened. So we had this, when I started the foundation, I got an initial team of 7, 8, 10 people who understood the health sector, understood the development sector, and to come up with the actual operating model of how would we implement this, what are the changes that we would make in the actual management of these primary health facilities, what are the quality metrics that we would track, et cetera, what were the results we could expect, et cetera. So then, and like I said, we wanted to focus on partnerships with state governments because in most developing countries, healthcare is implemented at the state government level, right? They are the ones who have the reach, the thousands of healthcare clinics. So if you want to have large-scale change, you have to partner with government. In India, we said, there are these 8 or 9 states in India, out of a total of maybe 30, 35 states, that are the large, low-income states in India. And cumulatively, they have a population of maybe 400 million people, 450 million people, which is about a third of India's population. But they account for 80 or 90% of India's healthcare challenges in terms of infant mortality rate, maternal mortality, et cetera. So we said, let's focus on those states. So when we developed our model, we said, of these states, who is likely to be the most open? And obviously, you need support right at the top level to do something like this. So we selected Rajasthan because in Rajasthan, the chief minister and her party had just gotten re-elected. Okay, she had been in power before, had developed, I shouldn't say some of this in public, but she had been voted out of power and then come back in. And then since she had just come in, before we approached her, there seemed to be this real new commitment about helping the common person and commitment to healthcare. So we identified someone in the health ministry in the state, went to them, and before going to them, we did a very detailed analysis of the state, district by district, issues, challenges, how our approach would help with all of this. And we presented a very detailed proposal to the senior person in the health ministry. Surprisingly, he liked it. And the fact that we were willing to put skin in the game, and I said, look, we'll cover the costs for the initial pilot period, et cetera, showed him we were serious about this. He said, we need the blessings of the principal health secretary. We went to him. He loved the idea. He said, no, but we need the health minister's approval. So we went to him. He loved it. And then he said, no, we have to go to Madam, the chief minister. So we went to her. I was there in the presentation. And to the credit, to all of their credit, they liked the idea. They were willing to give it a shot. They gave it a shot in a much bigger way than I expected. And that goes to the point I was saying earlier, which is now in many of these countries, India is an example, many of these developing countries, governments are now hungry for solutions in these fundamental areas of healthcare and education particularly. Those are the 2 building blocks for developing countries. Education is a little bit easier to deal with. Healthcare is a very complex system. So that's how it happened. And now, fortunately, since our model has been kind of proven, the word is spread, now we have this Delhi program also running. So now we have multiple state governments in India that have been approaching us and that we're in discussions with about implementing our model over there.
Krishna, I got kind of a 2-parter for you before I open it up to the floor. You talked about, the ability to find low-cost procedures for all kinds of things in India. How much of that can we actually learn from, and how much of that, knowing salary rates and that kind of stuff? I mean, how much of that can we actually bring back here? Do you have some indication? And also underlying that, if you think about that sort of healthcare delivery in India, I mean, I remember 10, 15 years ago, suddenly this notion about healthcare tourism sort of took off, and people said it's the next big thing, it's going to be huge. You know, never really seen quite as much stories bubbling up more recently about that. Was it oversold? Was it an idea before its time? So can those costs be translated, and will people take dramatic advantage of those costs in market?
Sure, both great questions. To the first, we do have some indications, both from modeling and also an experience. So there's an article in the Harvard Business Review a couple of years ago that looked at taking the model I spoke about, 2000, or at that point, what were they doing for $3,000 open heart surgery in India at Narayana Health, and looked exactly at the question of what is the labor cost arbitrage here, right? People get paid less. And so they did the counting, and if you changed all the salaries to US-based salaries, you could still do that procedure for $15,000. So rather than 2 or 3, it'd be 15, and the average here is anywhere from 75 to 100,000. That's still a transformative change that's possible, and that shows that it's not just a labor cost arbitrage issue that leads to these types of transformative changes. How that's being put into practice now is through a joint venture between Narayana Health and Ascension Health, which is the largest nonprofit health system in the US, that has led to the creation of Health City Cayman Islands, which now is open and is accredited by the Joint Commission International. And they are working with large employers as well as health plans to channel, as a center of excellence, large volumes of high acuity procedures. We see this play out in the US, where several large employers, including Lowe's Home Improvement, for example, have done deals with places like Cleveland Clinic to channel national volume to either singles or handful of centers of excellence. United Airlines just did a deal with Rush. The Rush Medical Center in Chicago is going to do all of the joint replacements for the company. So that business model that's being created, forget outside of the US, but the idea that people would be willing to travel and that employers and health plans would incentivize people to travel to places that, one, are the highest quality, and two, can do these where the unit economics also work, that their volume plays in addition to the quality, that the employers win and certainly the health systems win. And I think once you have that context, then the question becomes, if you're going to fly from Florida to Cleveland, it's actually closer to fly from Florida to Grand Cayman. Yeah. So why would you not go there if you were assured of the quality? And the price point in the Cayman Islands isn't as drastically lower, but it's 30 to 50% of the price point of the US. And if they can guarantee you the same quality in terms of outcomes, a better customer experience, and your copay is actually lower to go there compared to going across the street, I think those are the types of disruptive business models we're going to start seeing. And I think that relates then to your second question around medical tourism. That certainly still is an industry that continues to grow, but will never represent anywhere near a real material impact to big health systems. Where I think they can play a role is in being able to serve as a force for disruption. So what does a large employer get for signing some of these deals with centers of excellence? Sure, they may channel 2, 3, 5% of their medical costs and get some tangible benefits, but what they're really buying is market power. So every time you have to negotiate with all of your local health providers, if they know that you can fly your patients to different parts of the country or different parts of the world, then that's actually a disruptive force that's reducing price points in local markets, and that in turn is forcing providers to figure out how to actually lower the total cost of care instead of using market power. So I think there are secondary benefits to this idea of medical tourism, the idea that healthcare is globalizing like every other sector has done around the world, but I don't think medical tourism as a direct play is going to be the major disruptive force.
Well, my takeaway for life, of course, is always something that I can apply to myself, which is I should go to Cayman more. Sounds like so I've learned something here. But we've got a few more minutes, so I'm happy to take a few questions up here in the front. And Sid's got a microphone there. If you can stand up, let us know your name, the organization you represent, and keep it, if you can, to a pretty brief question here. We've got about 7 minutes to go. Thanks.
Yeah, Sergey Kostev, Financial University, Moscow, Russia. Will Trump presidency have any effect on U.S. India cooperation in healthcare innovation? Thanks.
Sorry, what was the question? What?
Will
Trump
Trump
president.
presidency have any ramifications for U.S.-India cooperation in healthcare innovations?
I don't think so. There haven't been that many, say, there are some small and interesting government-to-government programs on healthcare, but I don't know that there's anything major that's sort of out there that's kind of like on a decision tree. So I don't suspect that there's going to be any kind of major, but you know, a lot of, as I always say, with the U.S.-India relationships, it's driven by people below the level of president. So once we have some ideas too on who's going to fill out key roles, including the strategic and commercial dialogue, which you know this event is sort of organized under, then we'll have a bit more clarity. So I think, like a lot of folks, we'll wait and see the names that pop up in the coming weeks and coming months. Yeah, in the back row, Sid. Yeah, thanks. Yeah.
Good afternoon. My name is Todd Wiggins. I have a question about marketing of innovations, either here or abroad. And since you mentioned there are certain projects that are being or maybe going through the development process where they may need some scaling or promotion, is there opportunities in that area?
Maybe
You want to take it?
Sure, I think there are always opportunities to support, and a lot of the role that we play is really as a platform organization that brings different areas of expertise, different organizations like many of the ones represented here, to figure out and couple with individual or groups of innovators to be able to channel that capacity building support. So oftentimes we'll have an innovator that's looking at new market entry. So they've developed something in India and now want to move it to Latin America or perhaps East Africa. And we can link them to regulatory groups at a big company in the pharmaceutical or medical technology space that has that in-house expertise that can help them actually access in a much more efficient way the regulatory knowledge as opposed to trying to figure this out on their own as an entrepreneur. So I think we have mechanisms through programs as well as broader networks that try to facilitate matching of specific capacities and skills with where those are needed in different parts of the world.
Sunil, if I can ask you on that one too. I mean, for you, who now is operating a fairly large network, is it push or pull? I mean, I know you beat the bushes to find great innovations, but do you have people coming to you now and saying, would you take a look at this? I mean, how does it kind of work in practice in your space?
It's both. It's push and pull. So on the innovator and innovation side, like I said, we did this national search with the World Bank, and we have 200 innovators we've identified and we've started working with. But now that the word is spreading, now we have people approaching us every week, and we have partnerships with organizations like TIE, the Indus Entrepreneurs, FICCI, CII, industry bodies. So now we get innovations coming in all the time. And in fact, interestingly, the Indian government came to us 8 or 10 months back, and they said, look, there's a lot of interesting ideas within the government sector. Why don't you take a look at those? So we've done that, and we've selected about 50 innovations from government. So that's one side of it. And like I said, all the health clinics that we run and the 300,000 patients we're treating every month now give us a great test bed for actually demonstrating these innovations to government. So about 20 of these innovations which we've started working with, we're actually using those on all these patients. State governments are seeing that they work, and now they've started ordering these in volume. And when patients get exposed to this, that starts creating a demand factor for this. So it works. You have to work at both ends of this.
We got time for one or two more. Yeah, up at the front here. Again, name, organization, and keep a brief question if you can. Thanks.
Hello, my name is Ioana Di Fiore from the State Department. All amazing presentations. Thank you. Sunil, sir, I have a question for you. About continuity of these clinics. So once you start them, you renovate them, you hire, side question, where do you hire all these doctors? Where do they come from? I mean, for 200 clinics that you started in Rajasthan. And then how do you feel that the local governments like Rajasthan would stay involved? And
yeah, that's a great question. We have some thoughts on it. We'll have to see how it works out. The question is about continuity. How do you ensure that these changes that you're making kind of stay long term? So number one, what we look at is how do we get leverage, right? And get the maximum impact for what we're doing. So Rajasthan, again, just as one example, right? One state, 70 million people. The government's given us 200 clinics, but guess how many clinics the government itself runs? Just in that one state, about 10,000. 10,000. So here's what happened. So when we started doing this about 15 months ago is when we took these over. One of the things we told the state government, this was the first time ever they had partnered with the private sector. We're a nonprofit, but we're still private sector. And we told them, if the program works with us, why don't you expand the program? So 6 months ago, the government agreed to do that, and they've expanded the program from the 200 clinics that we're running to 1,800 clinics totally. We're not running all 1,800, but we helped the government plan the whole thing, develop the RFP, set up the public-private partnership unit to oversee. So that's one example of scale effect beyond the 200 clinics we're running. Then the government said, and this was the chief minister herself, she said, look, we've got these 10,000 other clinics that we're running. Obviously, you guys are doing something right. Can you develop a policy and procedure manual that we can implement at all 10,000 of these clinics? We said absolutely. So about 90 days ago, we gave her this policy and procedure manual. This is the chief minister. And they are going to implement them with all of these interventions that we have. So to me, if even 10% of it gets implemented, that could make a dramatic change. 2 weeks ago, I happened to be in Jaipur, which is the capital of the state of Rajasthan, met with the chief minister. She said, now how do we expand this? And she said, these 10,000 clinics, you've given me the policy procedures. Can your organization now help us oversee these clinics? Can you set up a monitoring system to oversee 10,000 government clinics? I said, we would love to, absolutely. So again, that's an example of getting scale effects well beyond the clinics that we're running ourselves. The agreement we have with the government is for the 200 clinics that we're running, we've put into place really detailed governance systems, accountability systems, make sure people show up for work every day. Patients are real people and not fictitious names that they come up with, which is rampant in these countries, in these health systems. We've got systems for all of that. So what we've agreed to with the government is at the end of 5 years, we will turn these 200 clinics back over to them, but the independent third-party monitoring will continue. So hopefully, some of these changes will get institutionalized. Now we have to see what actually happens in practice, okay? Still early days.
Well, we've reached the appointed time. Ranjan, I saw your hand there, but maybe you can grab somebody post. But